Welcome everyone to this 10th Let's Talk Medicine podcast from the Australian Doctors Federation. Tonight we're talking about the Kruk Report, the independent review of Australia's regulatory settings relating to overseas health practitioners. I'm Aniello Iannuzzi, the chair of the Australian Doctors Federation. I'm a rural generalist and I'll be hosting tonight. On the panel tonight we have Dr. Peter Cook from the Green Slopes Anaesthetic Services Group. He's an anaesthetist and has worked extensively in anaesthesia and intensive care, and is based in Queensland. We have Professor Philip Morris, who's the President of the National Association of Practicing Psychiatrists, and we have Mr. Stephen Milgate, who's the CEO of the Council of Procedural Specialists and the CEO of the Australian Society of Orthopaedic Surgeons. So welcome to all of you. We might start with Mr. Milgate. Mr. Milgate, why is this Kruk Report such an important document and such an important issue in Australian medicine?
Yeah, thank you, Aniello, for inviting me. Yes, the Kruk Report, which recommends an expedited specialist pathway of registration into Australia, is a monumental shift in the way that we have been accrediting overseas trained medical specialists. What it is advocating is that the established college system that we have, medical college system, which for those who don't know, medical colleges were established over 100 years ago throughout the Western world as an answer to major problems associated with delivering quality medicine in a free market. And it was actually the politicians who went to the medical profession and said, can you please establish some quality assurance programs and organisations that will focus on making sure that the public are safe and receive the highest quality of medical services. So a social contract was formed with medical colleges whereby they would do the training and standard setting, and they were recognised in legislation, and in return they could run their professional affairs, because only the medical profession really knows how to run its own professional affairs. So there's a social contract. Now, what this suggestion or this new plan, which is being implemented in great haste, I mean, it came out in June, July. It's due to be implemented in October. What is actually saying is that this system whereby medical colleges determine who's suitable to practice as a medical specialist by examination and supervision will be bypassed. And in fact, people coming into this country, and certain people that the government nominates, will be able to be instantly recognised as medical specialists based on an assessment of their training. We don't really know how that assessment is going to take place. Called equivalence. They'll be assumed to be equivalent in standard to the Australian specialist training college pathway, and they will be immediately able to work in Australia. And whilst they're working, they'll have some conditions on their practice, and they will be under some form of supervision. What level of supervision and how intense that supervision is hasn't been specified. And whilst being supervised at a certain period of time, somebody suggested 6 months. I've heard suggestions it could even be shorter than that. They will be signed off, and therefore those conditions will be lifted. So the bottom line is that we are about to see a new pathway into specialist training other than the college pathway. Now, that's it in summary. What's proposed, and there's a whole lot of reasons why that's been put forward. I won't go into that now, but simply it is a monumental shift, and there are major risks associated with such a shift, and I think that's what we're going to discuss tonight.
Thank you, Mr. Milgate. Dr. Cook, what is your view on the matter? Why do you think this is important, and what do you think the profession needs to do about this?
Well, I guess I would agree broadly with what Stephen has outlined. The Kruk Review came up with a number of findings. One was that we have the right number of doctors in Australia compared to international benchmarks of similar countries. However, it did point out that there is a maldistribution of medical practitioners, and I'd agree with that. I think there is problems with supply and delivery of health services, particularly in rural and regional areas. So the government has come up with one solution for the assessment of overseas trained specialists as being equivalent to Australian specialists, and has hoped that there would be a degree of oversight of these practitioners when they arrived in Australia. And I think we, in many fields, we need to look at specialist training and increase the number of homegrown specialists. And I think we need to do that regardless of the Kruk review. But I think we also have to look at distribution of specialists and make it attractive for specialists to, whether it be primary care or procedural specialists or other specialists, to work in both regional and rural and remote areas.
Thank you, Dr. Cook. Professor Morris, your thoughts?
Good. I have mixed feelings about this for a couple of reasons. One, because this is not new. In the field of psychiatry, we have seen graduates from overseas, albeit Australian citizens, being allowed to come back to Australia and not pass through the college training program. And that happened in the 60s and 70s, when a lot of Australian doctors who wanted to become psychiatrists went to the United Kingdom and became members of the Royal College of Psychiatrists. Not fellows. Fellows is the higher level of qualification, but they were members. In other words, they did training and they did their sort of registrar training years in the United Kingdom. Some of them had already done some of that in Australia, but they came back to Australia and they were not recognised by our College of Psychiatrists, which by that stage had started to develop its own training program and was believed it was the established way that you became a specialist psychiatrist in Australia. And they were virtually asked by the College of Psychiatrists, you join us or else. And most of them said no. And so they remained members of the Royal College of Psychiatrists, but for all intents and purposes, they were allowed to practice as specialist psychiatrists. Medicare recognised them, and many of them had hospital and other appointments, and they trained registrars. So this is not new. We've seen this before. Now, they happen to be mainly Australian citizens because they did Australian medical degrees and then they went overseas to do their psychiatry training and they came back to Australia. But they came back independent of the College of Psychiatrists. So it's happened before. It wasn't a disaster. Many of these psychiatrists have provided great service to the Australian community. They actually set up their own organisation called the Institute of Australasian Psychiatrists. And they had their own CPD programs and other forms of professional activities and basically run themselves as a parallel college. But they're only a small number, probably in the hundreds rather than the thousands in the College of Psychiatrists. So that's the first thing that I want to say. The second thing I want to say is I have also been an overseas medical specialist. I left Australia in 1987 to work in the United States. But when I left Australia, I was a fully fledged professional specialist in psychiatry. I was director of a teaching hospital psychiatric unit, and I went to America for a couple of reasons. One was personal, and the other was that I finished a PhD, and I wanted to see more serious academic research that was being done with brain imaging studies at Johns Hopkins University in the United States. Now, when I got to the United States, I was not recognised for anything. My medical qualification as just as a general doctor was not recognised, and my psychiatric specialty in Australia was not recognised. I had to spend 2 years getting a medical licence just as a general doctor and to get registered and board certified by the equivalent for the Australian College of Psychiatrists, the American Board of Psychiatry and Neurology. And so I had the experience of being an overseas doctor in the United States and went through that process. Now, I was very lucky because I could have had to face a period of up to 4 or more years doing a registrar equivalent training program in the United States. They call it a residency program. But while I was in the United States, the American Board of Psychiatry and Neurology, for one reason or another, I suspect it was because there were some people on the board that had come from either Australia, Israel, or South Africa, allowed doctors who'd come from overseas who had the qualification of the Royal Australian College of Psychiatrists or the Israeli College of Psychiatrists or the South African College of Psychiatrists to not have to do the 4 years of residency training. We could sit for the examinations immediately after we'd finished 2 years of residency training in the United States, which of course I did straight away and passed. So within 2 years, I passed the basic medical qualifications to be a doctor, and I'd actually become a specialist psychiatrist. What I learned from that is that we should, where we have an equivalence in terms of training, Australia training in psychiatry is very similar to the US training in psychiatry. I'm sure there are other countries from the United Kingdom and Ireland and places like that in the United States where training in pediatrics, internal medicine, anesthesiology, psychiatry is virtually equivalent. I think we should make it easy for those doctors to become specialists in Australia. And I don't know whether we need the colleges to do that. What we do need is clarity about what the standards will be and how they will be implemented. I think the Australian Medical Council will probably have a big role to play here because they have been somewhat sidelined by the medical board, but they really do have expertise in this field. And the colleges themselves have allowed themselves to get sidelined. They haven't been allowing enough people to come through some of these colleges. For what reason or another, I don't know. There's been some to say that this is because they're trying to protect the doctors who are in the community and stop competition. I don't know whether that's the case. But certainly in psychiatry, we need lots more psychiatrists in Australia. And of course, in general practice, we've only got, 15% of all doctors graduating go into general practice. We're going to have a huge shortfall in that area. So let's see what we can do to encourage and make our colleagues from overseas welcome and help them become specialists or general practitioners in Australia. But we just need to know what the details are and how this is all going to be monitored and how they're going to be supervised. So I'm sort of open to this. And to some degree, I think the colleges have brought this on their heads.
That's an interesting point of view, Professor Morris. And for those in the audience, as you can see, this is not a one-way discussion. We're open to all points of view at the Australian Doctors Federation. Dr. Cook, you've had a lot of experience with cases where this fast-tracking method has not gone to plan. Dr. Morris has outlined what he believes is a way forward. What are your views in terms of the pitfalls, and how should colleges and AHPRA and perhaps the Medical Council avoid problems that you've seen in the past?
Okay, well, I spent a decade as a tertiary intensive care director. I was also on the College Council, the Board of Directors of the College of Anaesthetists. During that time, particularly in the early 2000s, there were significant problems with budgets and staffing of Queensland regional hospitals. Queensland government, this is very important history to look back on and learn the lessons from. The Queensland government introduced the idea of people being deemed specialists. So people who were applying to become specialists were regarded as partially equivalent by the colleges. They would start work in a public hospital in a specialist role with a degree of supervision, sometimes on-site, but sometimes very remote. I'm sure there were a number of people who did meritorious service on this basis, but there were a number of disasters. There was a Royal Commission into the Bundaberg Hospital, where they had an American board certified surgeon starting to do enormous surgery, esophagectomies in Bundaberg, which is a smaller regional hospital. Harvey Bay had a report in relation to its orthopaedic department, which showed that there were doctors performing at the limit of their scope of practice who were supervised by an orthopaedic surgeon who was spending significant amounts of time in a city well over 200 kilometres away. There was problems at Mackay, and these are all freely available on the internet, the reviews into these. The problems at Mackay were ones of competence and supervision and communication between the colleges and the government. And when the politics questions were raised in Parliament, the supervising college and the supervising doctors were heavily criticised. So I think we need to be very careful proceeding down this path. And we also need to understand that just because someone comes from a particular country like Great Britain or Ireland or whatever, does not necessarily mean that they have practiced a significant amount of their career in that country. And so, you know, it needs to be approached with caution. We have a process for addressing this, and I'm particularly concerned about the supervision issue, because if problems arise, then the people who are supervising these specialists will be open to criticism. So I think it is quite a cause for concern for as to who will supervise these people, how closely, and what are the risks involved in doing that.
Thank you, Dr. Kruk. Mr. Milgate, you've been working in the area of health policy for over 3 decades now, and whilst you're very intimately familiar with health policy, you also have the benefit of being a bit arm's length from colleges and AHPRA, etc., because you're not a medical practitioner yourself. How have you observed this matter unfolding? And in particular, do you feel that the colleges offer an extra layer of safety and quality and security for the Australian public? Or do you feel, as Dr. Morris has suggested, that the current regulatory authorities are adequate at overseeing this process? And let me go a step further as well and ask you whether you feel that this problem is perhaps more relevant to some specialties over others.
Yeah, thanks, Daniela. I think the first thing that we have to acknowledge is that the college system has delivered a world-class medical profession. I mean, if you go to the recent Commonwealth report, Australia ranks number 1 for health outcomes. So all of us have criticisms of organisations, and obviously our medical colleges are in need of improvement and reform, and sometimes they do not adapt, but they do generate billions of dollars of voluntary training at a very high level for Australia's medical workforce. And this, as I said, the social contract or cooperative system, whereby our doctors actually train their competitors. This is unheard of in industry, that you would actually train your competitors. I mean, it does exist, but on such a massive scale. Who'll come out after you train them and compete with you for patients. And this contribution is funded by the profession itself. It's not funded by the taxpayer, it's funded by the profession itself. So when you have a system where you've got over 130,000 medical practitioners with a very sizable degree and investment in training on a voluntary basis, producing a world-class medical profession, any changes to that system need to be very, very carefully analysed. Because, as Philip pointed out, yes, there are frustrations with going from an overseas position, particularly if you're a highly competent specialist. We have a lot of doctors in Australia, medical specialists who've been trained overseas. They are brilliant. Many of them have made enormous contributions to the Australian medical profession. We need people coming into the medical profession to enrich it with their experience and expertise. Many of them I know personally have come through and sat the examination system. They've flown through the fellowship exams and the equivalence exams that they've done. And they're happy to do so because they're highly competent. Nothing is daunting to those that really know what they're doing. And they're out in the Australian community delivering and training the next generation of doctors. So this national asset, to me, on a broader scale, acknowledging some of the problems that exist and the bottlenecks that can exist in any system, we have to acknowledge the brilliant outcome that the college system itself has delivered because of the voluntary contribution of doctors. Now, you would think that if you are going to have a fast-track system that's going to bypass that you would carefully think about this and you would know exactly how this is going to work in practice. And Dr. Kruk has talked about the level of supervision. I mean, how are these people who are fast-tracked and registered as medical specialists put in a hospital system? What is the liability of the person supervising them? Should that person, the supervisor, decide that they're unsuitable for practice? We're told these people are going to be put through cultural safety courses or a test. What is the definition of a cultural safety test? What happens if there's a dispute over a person who's already a registered medical specialist with conditions, believes that they're quite competent and they're demanding to be signed off, and the person who's supervising them disagrees? What is the dispute system? Who decides who's right and wrong? Will the supervisors have legal protection? So these questions are just not answered, and yet we are told that this is about to be implemented. So it's very difficult to know, will a visiting medical officer or a public servant, a doctor, a full-time medical specialist in the public system, will they be told you have to supervise a fast-track medical specialist as part of your job? You don't have any choice. Is it a voluntary basis? And then the question is, what happens to the college system? What happens to our home-trained doctors who are going through that system and our overseas-trained doctors who've gone through that system? What happens to the future of that system? Or do Australian graduates find it easier to go overseas and train and then come back through this fast-track system? So many of these questions haven't been answered, and it worries me from a policy sense that it's hard to find the defined problem that this is a solution to. So Dr. Kruk has already pointed out that we have 130,000 odd people in the Australian medical profession. We have a very comparable world-leading number of doctor-to-patient ratio. We're producing the world's best outcomes according to the Commonwealth Fund. The system seems to be working. We do have shortages, as Philip knows, and as quite rightly pointed out, certainly in psychiatry. There are shortages. There are also regional and rural shortages in remote areas, as Aniela, you know, because you're out there in that area working, and Peter's worked as well in those locations. However, this doesn't appear to completely address this issue. We're not told that this system is going to make a difference in regional and remote Australia. There's no claim that it will. The only claim that I can find in the paper put out by the Medical Board of Australia is that some employers may find it easier to hire doctors. In fact, when we have a look at the patient safety statement, that's Appendix C of this particular registration standard, we find the medical board saying that as far as Indigenous Australians go, there'll only be small positive impacts from this system. They don't see any downside, but they base that on the fact that if there is, they will sort it out in the consultation that takes place with the system. But we haven't seen any results of that consultation. So if we're going to make this shift and we're rushing it through and experienced doctors don't know the details, I say we need to pause and make sure that there's not going to be unintended consequences.
Thank you, Mr. Milgate. That's very insightful. You've mentioned a number of important points there, and you've referred to the document itself. On reading the document, the problem that they're trying to solve, and you mentioned that you don't see what the problem they're trying to solve might be, but on my reading of the document, it appears that the problem they're trying to solve is access, getting patients' waiting times down, and also saving patients money. These are the typical things we hear in the media over and over again, typical things we hear from politicians, and of course, they're very important issues to patients. The Kruk Report seems to offer one solution, and that's to flood the market with more doctors and supposedly solve the problem. It's very heavy on that. As you've talked about, Stephen, it makes it easier to employ doctors if you're the government or if you're a large corporation. I don't believe it's going to be any easier if you're a small practice because the paperwork's going to be too hard to navigate. It's one of those typical policy gestures that you see over and over, not only in health. Let's just throw a lot of money at the problem and it'll solve itself. But unfortunately, that's not how you solve problems. This report is all about flooding the market with more doctors, and it says nothing or very little about why we have the maldistribution, why, for example, there are too few GPs and psychiatrists and anaesthetists as opposed to dermatologists and ophthalmologists and things like that. It goes nowhere in addressing the difficulties in setting up medical practice. It doesn't speak at all about the systemic issues we have in the mismanagement of our public hospitals, the red tape and costs of practice that are paralysing general practice and turning off young doctors from joining general practice. It says nothing about the red tape and difficulty it is to practice as a private psychiatrist in the country now. You can't get access to beds, you're reliant on the public service, all this mental health care planning and red tape that goes with it, and so it goes. So there's nothing that addresses the issues of why particular doctors aren't doing this thing. Our crisis in general practice at the moment is probably the most acute of all the specialties, and the Australian Doctors Federation has done 2 podcasts on this matter, and we drill into why the problem is the way it is, and we offer some solutions. There's nothing of that in the Kruk Report, and I think this is a real sad thing about the Kruk Report. It offers this opportunity to improve the system, reform the system, and yet it's gone nowhere to addressing the root cause of the problem. I'll hand over now to Dr. Morris. You've heard slightly different perspectives from what you offered the first time you spoke. Do you have any other perspectives as to how we're going to improve training and access and supply?
First of all, I was misquoted. I agree with Stephen. We do have a great system of medicine in Australia, great organisation. We do come first in virtually all these ways of measuring the outcomes in health compared to other countries, and it's primarily because we get the best health outcomes. We may not be the cheapest, we may not be the most accessible, but we certainly when you look at all these things, we tend to do better than most other countries, even countries that spend a lot more money in health than what we do per capita. So that's not a problem. The other issue is I'm not against the colleges. I'm just saying that there potentially are other pathways that well-trained people from overseas can come through. Now, the colleges have tried to make themselves more open to overseas trainees and welcome them more and make perhaps the pathways to getting them to become fellows of the colleges easier. I think they could do a lot more to do that. I don't know why the colleges are not going to the government, maybe they have, and said, look, we can fast track these people. Let's have a look at the sorts of minimum standards that are required from people from really good professional organisations or training in the United Kingdom, Ireland, France, whatever else. You can look at the medical skills they've been through. You can look at the type of training that they've had in various hospitals and other things, and you can make a scale of who's got good background and experience. So I think all that can be done. I think the point that Stephen makes is crucial. What is it that they're going to propose? And what are the checks and balances that are there in order to make sure that the Australian public is getting doctors that are going to be safe and effective and of high quality? So that's the important thing. We haven't seen that detail. So I would be very reluctant to just put a rubber stamp and say, yes, go ahead, without seeing the sorts of detail that both Peter and Stephen have been saying that needs to take place. Are they going to pay doctors to supervise people from overseas? Because as Stephen says, the colleges largely depend on a volunteer workforce of colleagues training their junior brothers and sisters. So that's going to be interesting. The problem is that we do have some shortages, and those shortages do need to be addressed. Is this the best way of doing it? All I was trying to say is that it has happened before. There have been pathways to becoming specialists that weren't through the established colleges here, and that we should be thinking about how we can make it as easy as possible for overseas qualified people to come to Australia and to become specialists and general practitioners in our community, obviously without making it, disturbing and limiting the capacity to make sure that the proper qualifications and show their skills. But I think we should be thinking about that rather than necessarily just saying it's not a good idea.
We have to also remember that getting registered and being allowed to practice is the first step, but then once you're registered, you have an obligation to do continuing professional development. And that under our current system requires a home or a hub in which you do that professional development. And it's almost always the case that has to be the college that your specialty pertains to. So it would seem a little bit anomalous to be letting doctors into a specialty and then expecting them to engage with the college regardless, and then the college is somehow stuck with someone who hasn't been trained by them to the Australian standards, learning how sophisticated our system is, and then perhaps set up for failure because they've been fast-tracked inappropriately. Dr. Kruk, what are your thoughts?
One of the things I'd point out is that Kruk Review did say that it takes 14 years to train a specialist, which is, perhaps if you look at it from one perspective, it would be true, but that incorporates medical school, going residency, going through registrar training. The actual specialist training is usually between 4 and 6 years. And we have a large number of people who are postgraduate year 3 and 4 who are very interested in specialist training, whether it be primary care or a procedural or consultative specialty. And so I think the Kruk Review emphasised that point, but it wasn't really a valid consideration in all the things we're talking about. The second thing I'd say is that if you have people come from overseas and they to fill a shortage in areas where currently people who are in Australia don't want to work, if you don't address the reasons why they don't want to work there, are the people who come from overseas going to stay in that area? And, you know, I come from Queensland. You know, we have enormous geographic challenges in delivering healthcare. But we need to make the positions attractive. And a lot of that comes down to organisational, industrial, a whole variety of issues. And beyond that, to opportunities for their kids, consultation, the amount of on-call that they have to do. There are a whole raft of issues that make many places unattractive to practice. And without addressing those issues, getting people in from overseas may not be a long-term solution for those areas.
Well, thanks everybody. It's been a very interesting discussion. I think we should go around the room now and conclude. We've heard about the Kruk Report, its strengths and its weaknesses. There are certainly some opportunities that it puts to our profession to improve workforce and access. There are certainly some dangers as well. Stephen, your concluding remarks?
Based on a lot of the comments that have been made, you know, that our experienced doctors and medical leaders, which are represented here, still don't know the detail, and neither does the public. And yet we're rushing to implementation. I think that's a red flag. We need to stop, revise, have a look at the system and just ask a lot more questions. I think the profession needs to take a more active interest. Colleges, I understand, we're told they've been consulted with. The college people that I've spoken to said, no, it's been presented as a fait accompli. So we read that the colleges have been consulted, and I have correspondence from politicians saying that the parliamentarians saying that the colleges were consulted, but I don't believe that they have been able to express freely some of their concerns. I think they've been told this is happening and your job is to implement it or go along with it. So that is a major concern when that happens. And so, yes, time for the profession to really have a closer look at this and call on the political decision makers to exercise great caution, because they're at risk as well if this system goes the way of the Bundaberg situation and other problems that we've had in the past from rushing things through. Political decision makers come into the spotlight. It's something that they should consider with a whole lot of caution.
Well, just to join
Professor
Stephen
Morris,
and say
your
the
concluding
profession
remark?
needs not just the colleges, but the colleges included, but the AMA and all the other organisations like the group that you are with, the Nilio, and start demanding the answers that Stephen was talking about. You know, how is this going to be done? What are the safeguards? What's the pathway look like? Where is the Australian Medical Council involved? Are the colleges actively engaged in providing support? All these things are important. One thing I'd like to say, and it's going back to Peter's point about Queensland, and I think this applies virtually all over Australia, we have huge numbers of junior doctors sitting in senior medical officer positions waiting to get into training programs to become specialists and general practitioners. Now, it's not so much the general practice area because they do seem to get that they've opened up their training program, but the other specialties, it's very hard for a doctor to get into a specialty training program. Some of them now, I've heard that they've got to do a PhD, they've got to do extra qualifications, extra degrees. It's just crazy compared to what it was like 20 or 30 years ago, when a person who has an interest in surgery would do 1 or 2 years, demonstrate that they've got some skills and have an aptitude, and then they'd go into training. But now they've got to go through a range of other things, including getting high degrees in medicine and research in order just to get into a training program. If those programs were made more available and easy to get through, we would be producing our own specialists in these fields. Now, why wasn't that looked at in great detail by this report? It seems to be something that has just been left, we've been blindsided on, but that's where we could generate a huge number of additional people. All these poor younger doctors are sitting around waiting to get out of the public hospital system through a registrar training program, but they can't because they're locked in. I think it's an incredible waste of the resources that we have right in front of us.
Thank you. Dr. Cook, your concluding remarks?
Yes, I'd say a couple of things. One is I have concerns for patients in general, and I think that is where I approach this issue, particularly understanding the history of with Queensland Health in the last 2 decades. If we were going to go down this path, particularly for procedural specialists, I think it's really important that the initial introduction to practice in Australia should be in a major institution where they can be supervised by a significant body of people and introduced into practice in Australia in an appropriate way. And I think that is unlikely to be how this will work out, in that it's more likely to be that people will be employed in difficult to fill positions with minimal or remote supervision. And I think there's tremendous potential for patient harm in all of that.
Thank you, Dr. Cook. So, in conclusion, we have the Kruk Report. The feeling around the room tonight is that it's an opportunity that perhaps hasn't been taken as fruitfully as it may have been. It's focused very much on inserting more doctors into the marketplace rather than focusing perhaps on how training could be streamlined within the college structures, how safety nets should be defined, and it hasn't looked at the reasons why we have the maldistribution that we have and why certain doctors are not doing certain specialties. So there's certainly more work to do. There's a feeling around the room that the college system is still serving our country very well and serving our patients very well in particular. It's over now to the profession to give this more serious thought and to give serious feedback through its colleges back to the government on how to improve access, how to improve distribution, and how to improve our training methods. We've heard some interesting thoughts, some interesting criticisms, some interesting suggestions, and I thank you for your time. We look forward to the next Australian Doctors Federation Let's Talk Medicine podcast, and see you soon. Thank you very much.